Now let's discuss scleroderma. So systemic sclerosis, it was previously called scleroderma. It is a multi-system connective tissue disorder affecting the skin, internal organs and the vasculature. So thickened skin, so scleroderma, thickened skin is the hallmark of this disease. It is more common in females. Okay, peak onset is in the 4th and 5th decade, so middle-aged females. So it is subdivided into two categories. So it can be diffuse or limited. So diffuse cutaneous systemic sclerosis and limited cutaneous systemic sclerosis. So the limited variety may have features of Crest syndrome, so calcinosis, Raynaud's, esophageal involvement, sclerodactyly and telangiectasia. So telangiectasia, vessels. Okay, so sclerodactyly and all that, so fingers and soft tissues and skin, and esophagus involvement. Okay. So etiology and pathogenesis. So exact etiology is unknown. There are many environmental factors such as exposure to silica dust, okay, vinyl chloride, epoxy resins, etc., which have been suspected. So basically what happens is there is infiltration of the skin by the T lymphocytes and abnormal fibroblast activation leading to excess collagen formation and fibrosis and thickening of the skin. So there is sclerodactyly. So fibrosis can happen in any organ leading to organ damage and functional impairment. So vessel wall inflammation and intimal thickening also leads to narrowing of the blood vessels. So again, systemic sclerosis can overlap with other autoimmune rheumatic disorders like sclerodermatomyositis. Okay, so tight skin and muscle weakness, indistinguishable from polymyositis. So polymyositis plus systemic sclerosis, so sclerodermatomyositis, and mixed connective tissue disease, so MCTD. So clinical features, see, Crest syndrome, 1R is for Raynaud's phenomenon. So it is seen in almost all patients and may precede other clinical features. So you can have erythema of the skin, which may precede the skin thickening. So thickening and hardening of the skin. So the skin of the fingers, the hands and the face is first affected. It becomes taut and shiny. The skin creases will disappear. Okay. So then thickening of the facial skin results in mask-like faces and microstomia, small mouth, parrot beak, nose and all that. Okay, so mask-like faces. Then skin involvement is restricted to, you'll see alopecia also, and skin involvement is restricted to sites distal to the elbow or the knee. Okay, it is limited cutaneous disease. So proximal to the knee and elbow and on the trunk also it is diffuse cutaneous disease. So musculoskeletal features, okay, it can be associated with other tissue disorders. So there can be arthralgia, morning stiffness, tenosynovitis, myositis, etc. Gastrointestinal features. Esophagus is involved in Crest syndrome for knees for esophagus. So smooth muscle atrophy and fibrosis, so that can lead to esophageal reflux. Again, dysphagia, so painful dysphagia. Odinophagia. Then you can have GAVE, so gastric antral vascular ectasia. So it is watermelon stomach. You can have upper GI bleeds and anemia because of that. Okay, and small and large bowel, again, if there is involvement in fibrosis, motility is decreased. Because of decreased motility, the food is stuck there. So you can have features of intestinal obstruction, so bacterial overgrowth, increased gas, okay, bloating, pain, constipation, and pseudo obstruction basically. Okay. Next, pulmonary features. Fibrosis, so interstitial lung disease. So again, there can be pulmonary hypertension leading to right heart failure, angina. So right heart failure again, pericarditis, myocardial fibrosis. Because of myocardial fibers being fibrosed, you can have arrhythmias as well. Conduction pathways can get disrupted. Then next, renal features. See, you can have scleroderma renal crisis. So it is a life-threatening renal disease, more frequent in patients with diffuse form. So it is characterized by acute onset of renal failure and malignant hypertension. Then neurological features. You can have neuropathies, peripheral and autonomic neuropathies, cranial entrapment. Okay. So headache, seizures, all of this. Then genitourinary features, again, if the penis, again, if you see fibrosis and all that, it can't become erect. So erectile dysfunction and decreased vaginal lubrication or constriction of the introitus in women because of the fibrosis. So diagnosis mainly clinical, okay, if you can't even pinch the skin, okay, if it is that thick, so systemic sclerosis, along with the presence of extracutaneous features and characteristic autoantibodies. ESR is elevated, anemia may be present, especially because of conditions like GAVA. Then skin biopsy, it is not usually essential, but if diagnosis is in doubt, go for skin biopsy. Autoantibodies, many autoantibodies are present, especially anti-centromere antibodies, anti-topoisomerase 1 or SCL, scleroderma 70. Okay, so ANA with a nucleolar staining pattern is frequently present. So X-ray and CT chest if you suspect ILD. Okay, so echocardiogram to rule out any pulmonary hypertension and cardiac involvement, right heart failure. Then RFT and urine analysis to rule out renal damage. So then management, so regular monitoring of BP, renal function tests and blood counts. So intravenous cyclophosphamide will slow the progression of the disease. You have to keep giving corticosteroids, especially if there is lung disease, ILD or myositis. Raynaud's phenomenon. So tell the patient to avoid cold exposure, use vasodilators like calcium channel blockers, so nifedipine, amlodipine, etc., and angiotensin 2 receptor blockers like valsartan. Sympathectomy can be tried if there is no response to medical therapy. Esophageal dysmotility and acid reflux, again give proton pump inhibitors and prokinetics like etopride, cisapride, and all that. So again, treat the infection of the ulcerated skin, and distal ischemia, you can give epoprostenol.